And so on that note, let's keep going and talk about the 4 categories of topical hemostatic agents.
Thank you so much, Dr. Davis. I think, while we were creating this course, we all had flashbacks to the clotting cascade in medical school. But thank you for that thorough review. So I would like to start by reviewing the 4 main categories of the topical hemostatic agents, or as we've kind of been abbreviating during this talk, THAs. There are a wide array of these available THAs, which can then be divided into physical agents, biologically active agents, and flowable agents, then fibrin sealants. So while I know this is a busy slide, we hope that this may serve as a quick reference in the future for you to review later. Much of this slide is going to be included in the information that I'm about to cover. So typically, we really try not to include brand names in these talks, but we really felt strongly as faculty that it would be important in this setting to share some of the more commonly used agents. This shows the brand names in their respective categories and also details the composition of each agent. So while categorizing the THAs in your head, it also may be helpful to realize that flowable agents, so we've included this kind of Venn diagram here to incorporate how the flowable agents have more than one category, as they are comprised of both the biologic and the physical agents. So just wanted to make everyone aware of that to kind of help organize our thoughts. I wanted to bring back the clotting cascade for just a minute. So understanding the clotting cascade is really the crux of understanding the mechanisms behind these various THAs. So now I'll just hop into briefly reviewing some of the more commonly used agents. I'll begin with the oxidized regenerated cellulose. Now, this is a physical agent. On the right, you can see a variety of Surgicel products that are examples of this agent. This can be applied directly to the tissue and will then create that scaffold for platelet aggregation that Dr. Davis was discussing earlier. This also decreases the tissue pH, which is part of the mechanism of action. This also activates the cascade and causes vasoconstriction that is important in this process. So in addition to knowing the agent's mechanism, we must also be aware of the time it takes for the agent you select for your patient to be absorbed, as that is important in the healing and postoperative process. So for the ORCs, this is anywhere from 2 to 6 weeks throughout the literature. Now we move to the microfibrillar collagen. This is also a physical agent. It comes in both powder and sponge sheet form and has a biodegradable matrix. This also absorbs blood and creates a scaffold for platelets. Similar to the ORCs, this agent activates the coagulation cascade as well. This agent may take as long as 3 months to be completely absorbed. So next, and still in the group of physical agents, is gelatin. Due to the sponge-like nature, once this agent is placed in your operative field, it slightly increases in both size and weight. The application of pressure to this gelatin for several minutes in this area of concern really creates the optimal results. Unlike the previously discussed agents, this has actually a neutral pH, so does not activate the clotting cascade. So that's important to note when selecting some of your THAs, is, again, knowing these mechanisms. Because of this lack of activating the clotting cascade, some may moisten the gelatin with topical thrombin before its use to further aid in hemostasis. The picture here shows that the gel foam sheets can actually be cut down. I think I'm the only one that does mostly laparoscopic surgery. So, being able to cut this down for laparoscopic application is going to be really important for physicians who are mostly operating in the minimally invasive setting. Absorption for this agent is anywhere from 4 to 6 weeks. So now we start shifting back to the biologically active agents. Topical thrombin may contain bovine, human, or recombinant sources. And I do just want to note that the bovine type can be associated with development of antibodies. This agent converts fibrinogen to fibrin in the final step of the cascade, while also activating platelets and causing smooth muscle cell constriction. Flowables really can be applied via a spray or a syringe, again, making it both applicable to open as well as minimally invasive surgery as discussed before. So this also can be used in combination with gelatins. An example of a thrombin plus a gelatin is FlowSeal. So the physical pressure from the gelatin component along with the active agent converts the fibrinogen to fibrin, resulting in that effective hemostasis that we want. The last category I want to mention are the fibrin sealants. These have both a thrombin and a concentrated fibrinogen component. So one thing really want to stress here is that this is the only agent that supplies its own fibrinogen for the clot formation. Some examples of this category are Tisiel, Tacoseal, and Vistaseal. And the components, as you can see here, of each are shown. So now that we know how these agents work, Dr. Lewis is going to delve more into how we select the appropriate agents for your patients.